Is it fine, sir, now?
Yes,
Yeah,
sir.
yeah.
Is the voice echoing there, sir?
No, sir. Now it's fine.
Now it's absolutely all right. Go ahead.
Right. Thank you so much, sir, for giving this opportunity for today's session. Thank you. Special thanks to Dr. Radhakrishnan, Madam Dr. Jayashree Sood, Dr. Shanish for taking this forward. And today's we are talking in an important session which is required for the purpose of cancer patients management, and it becomes important because when we talk about the cancer patients management, there are many issues that we should be taking care for, because it's just not a small surgical procedure, but it also requires the looking for various aspects with regards to patient optimization, with regards to the various comorbidity these patients have. And we also need to look for that these patients probably would have undergone some preoperative therapies, maybe in the form of chemotherapy or radiotherapy, that would have an impact on various organ systems. And we need to sometimes rehabilitate, and we use differently, or maybe pre-optimization. These patients may have pain also in the perioperative period, starting from pre or to post period. And these patients would lead to certain amount of insult to the physiology of the body, and that requires rehabilitation also. So this remains a very important aspect for good patient outcome. And in next around 45 minutes or so, we will take you through for the various aspects of pre-optimization. Along with me is my colleague, Dr. Pratishtha Yadav, who is specially trained in onco-anesthesia, and I think she is the best person to talk on this topic. So I will take you through along with her, and we will try to take out various aspects of the oncosurgical patients. Am I okay, Pratishtha?
Yes, thank you.
All right. So I think I will request Pratishtha just to enlighten us on the various aspects of the basic things that we talk about, maybe considering the anatomy aspect. And once we talk about anatomy, I think she will be taking us through a little aspect of the epidemiology of these cancers, which is important because when we talk about cancer patients, we'll be talking about their site, the impact, the clinical features, and then we'll take you through the various aspects. Am I right, my Pratishtha?
Yes, sir.
So we'll proceed.
And thank you, sir, for giving me this opportunity. Am I audible?
Yes.
Yes,
Sir,
Dr.
am I
Pratishtha.
audible? Okay, thank you. So, thank you, sir, for giving me this opportunity. We'll be discussing the pre-optimization, pain control, and rehabilitation. Discussion of is in the patient posted for esophagectomy. First, brief anatomy and history regarding important aspects regarding the CA esophagus. Esophagus, as we know, is a thin-walled hollow tube that extends from cricopharynx to the gastroesophageal junction, and it is around 25 centimeter long and is a muscular structure. And it has four constriction, as we know, like cricopharynx, at the point where the aortic arch crosses, then when it is crossed by left bronchus, and last is when it pierces the diaphragm. If you look at the epidemiology, it is 8th most common cancer worldwide and 6th most common cause of cancer-related deaths. And if you look at the incidence, globally, squamous cell carcinoma is the most common, whereas in developed countries, it is adenocarcinoma, whereas in developing countries, it is still squamous cell carcinoma. I have added these list of risk factors comparing adenocarcinoma and squamous cell carcinoma, and I would like to pinpoint towards the various factors that influence these different types of cancers. Like if you look here, there is alcohol, smoking, increasing age is a very important risk factor, especially in the squamous cell carcinoma. And apart from that, adenocarcinoma is often associated with gastroesophageal reflux, Barrett's esophagus, and obesity. As we know, these are the very important, significant comorbidities from an anesthesia point of view, and we should be very aware that these history are important in these patients when we are assessing them in the preoperative phase. So these patients may present with dysphagia, weight loss, pain, anorexia, cachexia, malnutrition, again a very important point. And these may have dehydration, anemia. Apart from the pathophysiology of the esophagus, C esophagus, These are also common in other cancer patients also, that is dehydration, anemia, malnutrition. These may have a risk of aspiration pneumonia. As we know, these suffer from GERD, and gastroesophageal reflux may be a part of history. Apart from this, we have to keep in mind the distant metastasis, invasion of the nearby structures. So the treatment modalities include three mainly: surgical, chemotherapy, and the radiotherapy. And the treatment lines depend on what is the stage and what is the type of cancers. We say here most of the patients require chemotherapy or chemoradiotherapy, followed by restaging and followed by a surgical resection.
So,
Surgery.
Dr. Pratishtha, what do you think on your clinical experience? How many of these patients would undergo preoperative chemotherapy and radiotherapy before these procedures are posted for surgical intervention?
So most of the surgeries, as we saw in the previous slide, that most of the patients undergo already have a chemotherapy or along with them radiotherapy, especially of the chest, as the esophagus lies in the thoracic cavity. So the chest area is exposed to radiotherapy also. And this is very important, as these chemoradiotherapy helps in reducing and shrinking the size of the cancer, as well as and makes it more amenable for the surgical resection. So most
I think
patients
this is an important point here, which Dr. Pratishtha is highlighting here, that when these patients comes to us, especially when we talk about the surgical intervention in lower esophagus and mid esophagus, these patients would be posted for preoperative chemotherapy or radiotherapy to make the patients, especially for surgical amenability. And hence, as we mentioned in the beginning, probably these patients would have side effects related to these therapies in the preoperative period. And then that's why we not only need to evaluate for these side effects, probably we also need to optimize to this certain extent. Am I right, Dr. Pratishtha?
Yes, sir. So we must also be aware of the different surgical modalities that are available, that can be done in these patients. There are mainly three types of ways in which the surgery can be performed. First is the transhiatal, second is Ivor Lewis, and third is a McEwen's. So in the transhiatal esophagectomy, as we can see in this figure, there are two incisions. First is in the cervical region and second is in the abdominal. As the esophagus is in the thoracic cavity, so usually the surgeon proceeds from the abdominal cavity into the thorax via the transhiatus to the diaphragm, and the blunt dissection is done. So as we can understand, this blunt dissection can lead to a risk of hemodynamical instability, as it's usually not visible and we are doing a blunt dissection. And there are a lot of major mediastinal structures include major vessels, and that can cause hemodynamic instability, as well as there can be a risk of recurrent nerve injury is also can be one of the risk factors in the post or perioperative period. And second is the Ivor Lewis. As we see, there are two incisions. One is the thoracic cavity and one is the abdominal cavity. It's there. This is the third. So in this, as there is an incision in the thoracic cavity, so one lung ventilation is required. Secondly, there's a risk of mediastinitis in these patients. And lastly, there's a McEwen's procedure in which three incisions are there. First is the cervical, thoracic, and as well as the abdomen. So as we discussed, preoperative chemotherapy and radiotherapy helps in increasing the rate of complete tumor resection, as well as better local tumor control and survival in these patients. So coming up to the anesthesia part, we have a case scenario here. Mr. X, 40-year-old male with ECOG PS score of 2, known case of esophagus, with a history of smoking 10 cigarette packs per day, alcohol intake, diabetes mellitus on OHAs, and hypertension, taking losartan atenolol. And this is a patient of post-anesthesia planned for transthoracic esophagectomy, came to the PSA room. So for the discussion point of view, what if this patient was not a 40-year-old patient, but rather it was a 80-year-old male patient? So if we look at the esophagus patient is very, as we look at the age that we receive the patients, most of the patients are elderly patients in the esophagus. Apart, if you look at the common geriatric concerns in anesthesia point of view, if you look at the different systems, First, the cardiovascular system concerns, that is in the elderly patients. These patients are mainly the tachycardic response is not very good. So most of the output is dependent on the preload. Secondly, their baroreceptor reflexes are not very good and they're suppressed. So the response of tachycardia may not be very good during the perioperative period. Moreover, these patients may be on some beta blockers in the perioperative period that can also blunt the tachycardic response to maintain the hemodynamics during the surgery. Apart from these patients may have atherosclerosis leading to hypertension and can have a labile BP during the surgery. And thirdly, these may have coronary artery disease, maybe patients of heart failure, maybe on anticoagulants or any other cardiac problems can be there. Now coming to the second system, pulmonary system. Pulmonary system, these may have decreased inspiratory capacities, decreased FRC that can increase the risk of desaturation and oxygen desaturation during these surgeries. And this is also important in esophagectomy surgeries as we require one lung ventilation and that can be also problematic during the intra period and we'll be discussing it later. Apart from this, these airway point of view, we know these are edentulous. These can have difficulty in airway manipulation. And then coming to the central nervous system, these patients nervous system is very sensitive. So to the anesthetic drugs, so lower doses of drugs may be required, and we need to be very careful while giving the drugs and anesthetic drugs and induction and maintenance of these drugs. The induction doses may be required in the lower doses, and titrated doses should be given. And even the MAC, when we are using inhalation agents, we should do a best monitoring so that, because the MAC requirement is usually 10 to 20% lower in these patients. And these patients may have some renal or hepatic morbidities for which we can also, we have to modify the amount of drugs and the type of drugs depending on the pharmacokinetics and the pharmacodynamics of these patients. Apart from these patients are more amenable to hypothermia, as these are prolonged surgeries, there are major fluid shifts, and we have to be very aware of these patients. Apart from this, in elderly patient, there's a concept of frailty that we'll be discussing. So, if we look at these patients.
This means you want to say that when we are looking for a patient of CA esophagus, there will be multiple aspects. So you mentioned earlier that one important aspect is what preoperative chemotherapy or radiotherapy or other treatment are received. So this is one of the important point which Dr. Pratishtha is emphasizing here. Secondly, when we talk about the common points, we understand that there may be some of the concerns, but they may also be related to the physiology of the patient that changes with the age. And when the changes with the age, we need to understand the physiological alteration into the systems of the body and the insult that these systems would have of the preoperative therapies that these patients receive. And hence, just not the evaluation and assessment, but probably to a certain extent, optimization is required. So I think this is the important point which Dr. Pratishtha is emphasizing. And now we'll be going into detail about each aspect that what you need to look for when these patients are posted for major esophageal surgery. Pratishtha.
Yes. So some studies have shown that advanced age is only a minor influence in the post-operative case, in the post-operative course and scenario of these patients. Age alone cannot be used as a prognostic indicator for the survival in this patient. This is a similar study that has shown that age is only a minor influence and it cannot completely rule and have a complete influence, major influence in the post-operative morbidity in these patients. So I'd like to emphasize and discuss few points on frailty. The frailty is actually a state of extreme vulnerability to physiological stressors that leads to adverse health outcomes. This was a concept given long way back by Fried et al., and it was mainly explained by the frailty phenotype. That includes major 5 points. First was these patients can be screened by decreased weight loss, sarcopenia, weakness, that is exhaustion, that is self-reported, maybe poor endurance, slowness, and low activity based on the different age group and the male and female. The patient was said to be frail if it is a positive for frailty phenotypes above mentioned. More than 3 criteria was present, or intermediate or pre-frail if 1 or 2 criteria were present. But this was soon replaced by a cumulative deficit model that said that more the number of morbidities, like more number of systems are involved, more the frail the patient is. Like functional decline is there, social vulnerability, cognitive decline, medical morbidities, inflammatoria, and sarcopenia. Inflammaging is something that is the elderly patients are supposed to be in a pre-inflammatory stage or pre-inflammatory stage in these patients and more vulnerable to complications. Overall, why I'm emphasizing frailty in these patients is because this increases the complication and unplanned intensive ICU admissions, increase the risk of complication, hence increase the length of stay, increase cost, and rate of discharge in this care facilities increased, and also increases the mortality. This graph is a very beautiful graph that can explain how it can affect the frailty, can help the recovery from the surgery. If you look here, there are 3 patients, A, B, and C. A, as we see here, is all these patients are initially preoperatively are functionally independent. Like A patient is mildly frail and is undergoing a minor procedure like maybe a lymph node dissection or a hernia repair. There's a minor insult and the patient post-operatively comes back to the initial preoperative functional status. Now you have a patient C. He is a moderately frail patient who has undergone a surgery like hemicolectomy surgery, and it is a moderate kind of an insult. There is a decline in the functional capabilities of these patients due to frailty, but soon the patient after is able to return to the initial pre-op is able to return to the functional capacity that is lower than the pre-operatively, and it takes a longer time. So depending on the insult also. And now we have another third patient that is a moderately frail and has suffered has going a surgery, like a patient has a strangulated hernia or is having an obstruction or peptic perforation that is poorly optimized, can be a septic patient. This has suffered a major insult. And the functional capabilities have decreased tremendously. And during the recovery, before he could recover, he suffers a second insult. The second insult can be in the form of MI. If a patient suffered from a MI during the perioperative period, or any aspiration or any chest infection or any aspiration or suffers, then second insult will further decrease the functional capability and the patient will never be able to completely functionally recover. So this gives us an idea about how frailty can have a negative impact on the recovery from the surgery. This is a this study was done to assess the morbidity and mortality after esophagectomy during a modified frailty index. We'll discuss the frailty index later on. It was seen that whenever the frailty index increased from 0 to 5, the rate of serious complications in ICU admission increased from 18 to 61%. That is a huge amount. And the mortality rate also increased from 1.8 to 23%. So the frailty can have a huge impact on the perioperative morbidity in these patients. Apart from frailty phenotype that we discussed given by Fried, these are the different scales and indexes that are available. The most common is the 11-point modified frailty index. The difference we see from the phenotype here is it has included the different, apart from functional health status, diabetes. It has included the morbidities like diabetes mellitus, COPD, heart failure, MI patients, those patients who have undergone coronary interventions. There's impaired sensorium, TIA history, cerebrovascular accidents. So it is a wholesome kind of an index. It was soon replaced by a new 5-factor modified frailty index that included only 5 factors: diabetes, hypertension, CHF, COPD, and functional status. It was a study showed that these are all the impact, the predictability of both the scores, whether 11 or 5, is almost similar. So even if we find a preoperatively a frail patient, so how can we help these patients? So there comes a role of rehabilitation. We should always look out for the factors that we can improve and optimize in preoperatively. We saw there were a number of morbidities that were part of the frailty index, like diabetes, hypertension, smoking. So we need to optimize these patients preoperatively, and there's no clear-cut guidelines for doing that, but we should always emphasize on identifying and predicting the complication in the post-op period those who are the high risk, and also try to optimize preoperatively these patients carefully the first time we meet these patients in the PSC clinic. So further seeing, there are other morbidities in this patient like diabetes, hypertension, and post-NSCT. So what can be the complications of cardiac considerations? We'll go by system-wise. So cardiac consideration in these patients. As we know, the esophagus, we require one lung ventilation. So the common complications include the pulmonary complication, followed by cardiac complication, and third is surgical complication. Out of which the pulmonary are the most common, but the cardiac complication are also quite significant in these patients. And arrhythmias are the most common after esophagectomy surgeries and can occur in 20 to 30% of these patients. And among this, atrial fibrillation is the most common. And it is seen that these patients have an increased hospital length of stay and increased risk of postoperative death. This was a stratification by thoracic surgical procedures for postoperative atrial fibrillation. The patients or the surgeries can be divided into three: low risk, intermediate risk, and the high risk, that is an incidence of more than 15%. We see here that the esophagectomy or the thoracotomy, pleurectomy, pneumonectomy, and the surgery of our interest, that is esophagectomy, comes under high risk. That is a risk of more than 15% in these patients. So we should be aware that what complications we have to face in the perioperative period also. So how is it important? How can we modify this thing, the incidence of this? There are not modifiable factors as well as non-modifiable factors. Non-modifiable factors like increasing age, male sex, Caucasian, or patient is already there's a risk of arrhythmias in these patients. So we should not be bothered about them, but we should keep our focus on the modifiable factors like hypertension, MI, heart failure, LVH, obesity, OSA. Those patients who have a smoking, alcohol abuse history, and hyperthyroidism. These are the factors we should focus always in preoperative and PSA clinics, and we should try to optimize these patients. So for the cardiac evaluation, we have a routine ECGs, echocardiography is indicated, and more wholesome tests are exercise stress tests, coronary angiography whenever is appropriate, and CPET. We'll discuss it in the coming slides. That can help us giving a more comprehensive idea about the cardiopulmonary function test as a combined. According to the AATS guidelines, they have given the criteria and guidelines for how to manage the perioperatively atrial fibrillation. They have given prophylaxis followed by the treatment also. So in the prophylaxis, the patients have been divided into three groups. First is what to be done in all the patients, intermediate to high risk patients, and what are the highest risk patients. So in all the patients, they have strongly emphasized with the class 1 recommendation that if the patient is already on beta blockers, we should continue beta blockers perioperatively, as also we have seen that it helps in decreasing the cardiac morbidities and cardiac complications. Apart from this, class 2B recommendation, if the patient has a lower magnesium level, we should correct it preoperatively. And if the patient is at a high risk of total body depletion is suspected in the perioperative period, we should also correct it. But it has not, it has recommended against use of digoxin or catheter or surgical PVI. Now, for the intermediate and high-risk patients, 2A classification is given for IV amiodarone and 2B for amiodarone in esophagectomy patient with a level of evidence B. Apart from this, diltiazem for patients with preserved left ventricular ejection fraction if they are not taking beta blockers, and also atorvastatin for statin naive patients with a level of evidence C only. For the highest risk patients, left atrial appendage excisions may be considered at the time of the surgery, but its level of evidence is only C. So, should we actually give beta blockers or amiodarone in these patients? Even the ERAS guidelines have said that the beta blockers are to be given, and they've shown to decrease the postoperative MI and supraventricular arrhythmias in these patients. If the patient is on beta blockers, we should continue these perioperatively. If the patient is not on beta blockers, this is actually a gray zone. It is not recommended to immediately before the surgery to start the beta blockers because of the side effects. But as it can be started like 48 to 72 hours preoperatively. Apart from that, for the amiodarone part, they have said that the current evidence does not support the reduction in length of stay and overall morbidity and mortality in these patients. But we should always, they have again focused on the fact that we should aim to reduce the modifiable risk factors and prompt recognition and treatment of associated or contributory complications. And apart from this, we should be very cautious while using amiodarone because it has seen that it can lead to complications like hypertension, bradycardia, and QT interval prolongation, as well as if the patient is pneumonectomy patient, these have shown to have lead to ARDS in these patients also. So we have very clear indications to continue beta blockers, but for amiodarone, we should be very cautious while using them. So now coming to the pulmonary considerations, as we know, we are going to do one lung ventilation, and the patient we have is a smoker with 10 cigarettes per day and also alcohol intake. And PFT report shows FVC of 80% and FE1 of 70% are predicted, and a poor oral hygiene is also there. Plus, there's a history of post-NSCT also. So we already know that pulmonary complication, as we discussed, is the most frequent complication that is seen in esophagectomy patient, around 20 to 40%. And despite of the advances, all the patients should be prepared for the possible thoracotomy in these patients. So pulmonary testing is often indicated in these patients, and IRAS has also supported that the use. The patients with a compromised pulmonary function have, as evidenced by FVC of less than 80% and FE1 of less than 70% of the predicted, have shown to have increased risk of pulmonary complication. And even if we have these parameters or PFTs, we should always go for preoperative rehabilitation and training in these patients. That is, even if the patient is preoperatively completely normal PFTs, there's always a risk of deterioration in the post-op period.
So, Pratishtha, you were talking about the cardiac complications initially, and then you mentioned about the pulmonary complications. And I understand when we go for the esophageal surgeries, there will be impact on both the functions. So it becomes very important to assess it. Do we have some newer tool or relatively a newer tool that will probably help us to identify the cardiorespiratory reserves, or maybe I can say broadly the cardiorespiratory system, that will not only help us to look for the risk stratification, but it will also help to make the perioperative planning. So do we have some tool, and can we do something for this?
Yes, sir. As discussed in the previous study, we have a tool called for the functional assessment. We have a cardiopulmonary exercise test that is available. That is very new and very upcoming step we have it there. It is basically a test which, as we know, during the exercise, when we have to deliver the oxygen to the muscles or any organ that is to the different organ system and the tissues, we need a combined functioning of the cardiac and the pulmonary system. And it is a very important tool that checks the integrity of the cardiac as well as the pulmonary system. In general, VO2 max of more than 15 ml per kg per minute and 80 of, that is anaerobic threshold of more than 11 ml per kg per minute has, less than 15 and less than 11 has been shown to associated with post-operative complications. And in the studies that are specific to esophagectomy, we have seen that VO2 max of less than 17 ml per kg per minute. And in another study by Nagatsu, VO2 max of more than 800 ml per minute has been is minimum required for the esophagectomy patients. And also, if we look at the IRAS guidelines, they have emphasized that a CPET can be used to assess the patients undergoing the major surgery, mainly to guide the preoperative optimization of these patients. Secondly, to predict the postoperative complication. And lastly, to assess the patient, those who are of borderline resections, whether these patients, if when you take the risk in these patients to do a high-risk surgery, whether these patients will have a high risk of complication in the post-op period due to the cardiac and pulmonary morbidities or not. So it is a highly expensive tool. It is not readily available. So we have an alternative for this, that is to test the cardiopulmonary function. We have 6-minute walk test and also shuttle walk test. Moreover, we know that these onco patients undergo chemotherapy. So this is and these have a decrease in the post-operative period. These have a negative impact on the cardiac and the pulmonary system. So it can CPET can also help in identifying these patients, and studies like in this study, they have shown that there's a decrease in the anaerobic threshold post neoadjuvant chemotherapy in these patients.
So I think you rightly mentioned that the use of CPAT becomes important, and you also mentioned that though we expect the major centers to use this facility for evaluation and use it for optimization, and people have used CPAT also for rehabilitation purpose also because it provides a lot of training. But the other option is this may not be available at many centers. We do have alternatives. It has been quite validated, but if you go for the objective tooling, you rightly mentioned, CPAT should be done for these patients specifically for those who are at high risk or who has underlying comorbidity. Absolutely fine. Pratishtha, what do you think? When you take care of these patients, you already mentioned about the various assessment tools. You mentioned about the impact on the systems. But sometimes we are really concerned in these type of surgical procedures that they will have some issues in the post-operative period. And that's a theme for today's session also. So when we talk about the post-operative complication, one of the issues will be the respiratory complications. And among we usually label them as PPCs, post-operative pulmonary complications. These patients may require thoracic intervention also. There will be handling of the lungs, and that will lead to, in fact, some compromise to the respiratory functions. Do you think, can we do something for it? Can we pre-operatively try to optimize that we can decrease these PPCs in the post-operative period? Do we have some tools or strategies, Pratishtha?
Yes, sir. We can. Then comes the roles of rehabilitation or rehabilitation in the perioperative period. Like this patient was a smoker, so I will first and foremost ask this patient to stop the smoking. Secondly, we will stop the smoking. Secondly, we can ask the patient to we can advise these patient about the respiratory exercises by increasing their motivation and educating these patient. The common instrument that is used here we see is an incentive pyrometer. That is, apart from this, respiratory exercises, deep breathing exercises, diaphragmatic strengthening exercises can be prescribed. If a patient is of COPD, we can prescribe bronchodilators that can help in dilatation of the airways, like inhaled beta agonist, ipratropium bromide, or inhaled steroids can be prescribed for optimization. And these patients may have, COPD especially, may have thick secretions. For this, we can suggest systemic hydration, airway hydration by humidification or nebulization, so that these secretions loosens up and we are able to drain these secretions by cuffing out, say, physiotherapy or postural drainage. Apart from them, if the patient has underlying infection, we should make sure that we treat the infections by antibiotics in pre-operative period. And smoking is a very cessation of smoking, no matter how for short duration, we have to stop it. We have to emphasize and make the patient understand to stop the smoking. As we see here, the timeline, how it affects the system, we see within the 12 to 24 hours, there's a decrease in the carbon monoxide levels and nicotine levels. Within 2 to 3 days, there's a decrease in the carboxyhemoglobin and the ciliary function starts to improve. Within 1 to 2 weeks, there's a decrease in the sputum production, and PFT start to improve by 4 to 6 weeks, around 1 month. And by 8 to 12 weeks, that is 2 months to 3 months, there's a overall decrease in the post-operative morbidity and mortality.
So this means that when you try to pre-optimize these patients, depending upon the time, probably we may not be able to give every patient's duration of 8 to 12 weeks because the cancer surgeries are labeled as time-sensitive surgeries. But we need to understand this slide becomes important because each pulmonary function will be impacted with the duration of the smoking sedation. So whatever beneficial effect the time permits, we should give them. And we should also understand, for example, if you're talking about the immune function, which could be compromised in these cancer patients, and if you have, say, a patient that just stopped for 2 to 4 weeks, the cumulative effect and the side effect will be additive, and we should be cautious that these side effects can be taken care of. Pratishtha, you talked in the beginning that even the alcohol has impact. It's one of the, in fact, risk factor for these esophageal carcinomas. You mentioned about the smoking. Do you think the same effect, the time-sensitive effect, would also be there for the alcohol also?
Yes, sir. Alcohol is also very important. Its history. It can negatively impact the immune system in these patients. they have increased the endocrine stress response during the surgery. It can has a negative impact on the blood coagulation, as well as it can lead to post-operative complications like wound healing processes. As per the IRAS guidelines, they have recommended smoking and alcohol both to be stopped at least 4 weeks prior to the surgery, and it should be emphasized during the pre-op checkup period, and very strongly emphasized actually.
Right. So I think we have talked many things till now, and we were talking about, you started with the basic epidemiology of cancer. We tried to cover about the various type of cancers. We did talk about the age-related issues, and you have touched on a very important topic, which is mostly ignored, and we are not aware of it. So I think we have covered up an important topic of frailty. It's one of the upcoming concerns in the perioperative period, specifically patients with chronic disease, specifically with cancer patient, and you have nicely covered it, how to assess them. And probably this is one of the predictors of various perioperative complications, and we should be a little careful about it. You also mentioned about the assessment tools for these patients with regards to the cardiorespiratory system. You nicely mentioned about the upcoming importance of the CPAT, cardiopulmonary exercise testing, not only for the purpose of assessment, but it also helps in risk stratification. It can also be used for rehabilitation. So we have covered many aspects, and you also mentioned that the smoking, the alcohol, one of the risk factors for these patients of having cancers. What needs to be done for them? How much time is the good time for cessation or abstinence for these patients? Pratishtha, we were talking in the beginning that these patients probably would receive the chemoradiation, sometimes as a neoadjuvant chemoradiation therapy for these patients as a part of treatment. And if I give you this patient, which is the 40-year-old male patient with echo PS of 2, known case of esophagus, we mentioned about smoking, alcohol, known case of diabetes, hypertension also. Now, this patient, as we mentioned, has received the neoadjuvant chemoradiation, right, including the paclitaxel and carboplatin. Usually, these patients, as you know, receive radiation therapy for around 25 fractions, which is dispersed 5 days a week and continues for 4 to 6 weeks. And subsequent to it, these patients are awaited for around 4 weeks till the side effects of chemoradiation comes up. And then within 4 to 6 weeks, these are posted for surgical procedure, isn't it?
Yes, sir.
So what do you think, what we should look for when these patients are posted for? What do you think will be the impact on the patient that we should be looking during the initial part, maybe for the purpose of assessment, maybe if it requires optimization? So can you just show some highlight on these aspects also?
Yes, sir. Apart from the beneficial effect of chemoradiation therapy, that is a killing of the cancer cells, these have some effect on the normal cells, normal functioning cells, and that has a gross impact on all the systems of the body. And the most common side effects that we following the chemotherapy that we come across is the nausea, vomiting, loss of appetite, there's oral sores or oral ulcers are there, dysphagia is there, diarrhea, constipation is there. Esophageal carcinoma patients, as we know, these patients with dysphagia, loss of appetite, difficulty deglutition. So these are already nutrition deficits. And along with these during the chemotherapy, these patients, if they suffer from nausea, vomiting, oral sores, dysphagia, these can further have a deteriorating effect on the nutritional status, leading to the further severe malnutrition from this surgery. Apart from this, if the IRAS guidelines have given about the timing for the surgery in these optimal timing for surgery in these patients, they have specified that for the neoadjuvant chemotherapy patients, there's a minimum of only chemotherapy, minimum period of 3 to 6 weeks, and for chemo plus radiotherapy, 6 to 10 weeks is required. And if we look at the system-wise impact of these different chemotherapies starting from the above, if we look at the cardiovascular system, the common these chemotherapy drugs can have a very negative impact on the cardiovascular system. These can cause, patient can cause, can increase the QT prolongation. And if we give these patients any other drugs, like commonly drugs like ondansetron or granisetron, that can further increase the QT prolongation. This can precipitate oscillatus pointers or arrhythmias in these patients. Apart from this, these can lead to, these can have left ventricular dysfunction, heart failure, in these patients can also be seen. And the common drugs includes doxorubicin, daunorubicin, then we have paclitaxel, then we also have incretin and blastin. These are the common chemotherapeutic drugs that can have a negative impact on the cardiovascular system. So from the anesthesia point of view, we should be aware which chemotherapy drugs can have a cardiotoxic effect. Secondly, we should have a baseline ECG, echocardiography evaluation of these patients. And if we are suspecting that there is a risk of heart failure or LV dysfunction in these patients, we should have echocardiography done or the functional assessment should be done. And some guidelines have shown that the patient has a left ventricular dysfunction or have a heart failure. These patients can be prescribed AC inhibitors or ARB inhibitors preoperatively, and this can help in increasing the LV function of these patients and also decrease the incidence of heart failure. And arrhythmias you already discussed, we should avoid the drugs that can increase the QT prolongation. We should have electrolyte imbalances should be corrected in these patients, and we already discussed the atrial fibrillation. So
this means that when we talk about the post receival of the chemoradiation, we have to balance two things. One, the damage that could have happened to the normal physiology because of the administration of chemoradiation will take some time to recover. And you have nicely summarized the various impact on various physiological system. And you rightly mentioned and emphasized that it would require maybe around 4 to 6 weeks for them to recover. If you are using the combinations of chemo and radiotherapy, which is most of the time required for these patients, probably they will recover a little more time. And that's why you rightly mentioned that we have to wait. We cannot wait for longer duration because the beneficial effect that we have achieved in tumor regression using the chemo radiation will go off. So we have to take the advantage of the optimal effect of these therapies vis-a-vis the timing of surgical procedures. And this is the usual timing, and many of these side effects that we have just described will be spontaneously resoluting, but some may persist, and that's why you rightly mentioned that we have to look for the assessment of these patients.
So if you look at the other systems that we have respiratory system, these especially the radiation can cause radiation pneumonitis. Apart from this, some drugs like bleomycin, the cyclophosphamide, and vincristine and blastin can also have negative impact on the lung functions, like it can cause interstitial pneumonitis or hypersensitivity pneumonitis, or can also have veno-occlusive diseases, pulmonary embolism also. And apart from this, there are common paclitaxels or cisplatin group of drugs that can lead to renal dysfunction preoperatively and hepatic dysfunction also. Renal function is very important because these, if they have nephrotoxic drugs and also some other surgeries like in CRS hypex surgeries where cisplatin is used, we should be very aware of the nephrotoxicity of these drugs. And we should always protect the kidneys from any further damage, avoiding NSAIDs or any nephrotoxic drugs, and we should maintain optimal hydration and optimum perfusion of the kidneys also. And if the patient has hepatotoxic drugs, these patient can have coagulopathies, and so that is very important for us as these can have deranged INR, and while giving regional anesthesia, we should be aware.
Right. So you rightly mentioned that we have to look for all those side effects, probably try to optimize them, and the residual impact which may sometimes be seen in these patients should be considered in planning the perioperative care for these patients, and probably sometimes it is stratification. Pratishtha, do you use this scoring system of these patients? Do you think this is beneficial? Should we go ahead and do it routinely?
So this is a new score that has come up, that is preoperative esophageectomy risk score, and it includes mainly 3 scores that we commonly use independently. First is the RCRI score that every anesthetist knows. Second is the pulmonary function test, or that is PFTs, and third is the MELD score. Then it has the studies have shown that PER score can be either 1, 2, or 3. And if the risk is if the patient belongs to 2 and 3, that increases almost doubles the risk as compared to the PER score of 1. So it can be routinely included in our evaluation, but always, even if we are stratifying, we are predicting the post-operative complication. We should always focus on which factors we can optimize preoperatively, so the patient doesn't land up in the higher risk scores and land up in more complications in the post-operative period.
So probably the combination of these scoring system would help us to look for that whether these patients will be tolerating these major surgical procedures, and we can combine them. It will be a good idea, not only for the purpose of planning, but also risk stratification, and we can plan these cares for appropriate management. And that's why you rightly mentioned that the score significantly predict the short-term outcome of these patients who are undergoing surgical resection, for especially the major surgical procedures. And higher the score, probably more would be the morbidity and mortality as compared to the lower the score. So this will help us to probably think of whether these patients will be able to manage or tolerate the surgical procedures, or we need some more optimization, or maybe sometimes the assessment also. Rightly, I think we have tried to cover majority aspects. But Pratishtha, do you think to my understanding, these patients will have difficulty in eating also because they have some esophageal obstruction? And as my clinical experience, these patients would have a lot of pain also because when they receive chemo radiotherapy, they will have a lot of mucositis, isn't
Yes,
it?
yes, sir.
So do you think nutrition is a big issue in these patients? Maybe if I give you one of the patient that we had, the 40-year-old male patient, same we were discussing earlier, and during the progression of the disease as well as the preoperative therapy, patient has a significant weight loss, and that is commonly seen in the cancer patient, isn't it?
Yes, sir.
And when we go for looking for the other aspects, patient will not be able to eat, maybe because of tumor progression, and maybe because of the
Side effects.
edema also, and mucositis also. And we also understand the study says that albumin is the independent predictor of poorer outcome, isn't it?
Yes, sir.
And these patients, because of this nutritional aspect, will have low hemoglobin, low albumin, low any nutritional indexes that we'll to look for. So what do you think? How should we go about it? Do we need some assessment? Do we have some scoring system? Can we build it up preoperatively? Or any other thing which you want to share?
Yes, sir. It is a nutritional build-up is a very important, very important aspect of the prehabilitation in all the patients, whether it is an oncology or non-oncology patients. And ESPN guidelines have clearly specified that there are 5 factors like severe weight loss of more than 10 to 15% in 6 months, or low body mass index of less than 18.5, and subjective global assessment grade of C, or albumin level of less than 3 gram per DL, in absence of hepatic or renal failure. These patients should receive preoperative nutritional support at least in the preoperative period. And subjective global assessment and subject sorry for the missing part of the slides. So subjective global assessment form is a form that has a various different aspects that subjective global assessment grades the patients into A, B, and C. It is a very comprehensive form that takes about 15 to 20 minutes. And if the patient belongs to the grade C, then it can the patient needs a preoperative assessment as well as needs a nutritional support. The patients can be grossly classified into low risk, moderate risk, or high risk. Low risk patients are those who have normal intake or a minimum weight loss. These only need dietary advice for around 5 to 6 days preoperatively is good enough to encourage them to have a dietary intake. Second is a moderate risk with anorexia, dysphagia, and unintentional weight loss of 5 to 9%. These usually require protein energy supplements, protein powders, supplements, along with the exercise should also be recommended in these patients. And the last is the high risk with a severe dysphagia of fluids only, with unintentional weight loss, like in our patients of more than 10%, and or body mass index of less than 18.5. In these patients, enteral support is commonly used with, commonly given advised with tube feedings, especially in the esophagus patients. In the complete dysphagia of these patients can have gastrostomy or jejunostomy that help in building the enteral support to these patients. And there should be at least these, and especially in the sarcopenic patients and the frail patients, the ESPN guidelines have recommended that they should be given prehabilitated or nutritional support should be given at least for 4 to 5 weeks along with the physical exercise component. So we have to, we always receive patient around 2 to 3 weeks preoperatively. So we should encourage the nutritional, and we should send them to the dietitians, those who can certify and give them dietary advice and encourage them also. So the common target ranges as prescribed by the ESPN the 20 to 30 kilocalories per kg per day of energy and 1 to 1.5 gram protein per kg per day in these patients, along with the multi-mineral supplements.
Right. So you mentioned about Pratishtha, that nutrition is important aspect because of the disease process itself, and probably because of the neoadjuvant chemoradiotherapy, these will have impact on the nutrition also. And hence it requires some subjective assessment is not good. We need some objective tool. And you rightly mentioned one of the very good validated tool is the subjective global assessment form, which gives a very nice assessment of these patients. And we need to supplement nutrition, because even for these time sensitive surgeries, still they are workup. And when we said about the chemoradiation therapy, we still have 2-4 weeks you mentioned, and we can start them on nutrition. But there's always a dilemma when we start on these patients. We have enteral route and we have parental route, isn't it?
Yes.
People will think that parental route will directly give all aspects, and since this is esophageal carcinomas, they may not have good objection. So what is your opinion that should we go for enteral nutrition in all patients, or parental, or what do you suggest?
Sir, SPEN guidelines suggest that oral route is always preferred, followed by enteral or parenteral. Enteral is always and we should shift to enteral or parenteral only when there is a oral nutrition intake of no oral intake of for a week, or oral energy intake is less than 60% of the requirement for more than 1 to 2 weeks. And if the patient is not able to take enteral requirements, that is 60% is not met, then we can only shift to parenteral, as there's a risk of infections and electrolyte imbalance in the parenteral nutrition. As we discussed, these patients esophagectomy, absolute dysphagia is there. They already have an enteral route. Gastrostomy or jejunostomy is already always there. So we'll always prefer that. Then another aspect of nutrition is immunonutrition. These ERAS guidelines usually are not very, they have stated that there's a lack of evidence for giving routinely immunonutrition in these patients. But SPEN guidelines have showed that the immunonutrition like arginine, omega-3 fatty acids have a beneficial effect especially in malnourished and major cancer surgery patients. And we can recommend immunonutrition in preoperative and at least in the few days up to 1 to 2 weeks in the postoperative period also.
Right, perfect. I think you rightly mentioned that these patients would require appropriately pre-operative optimization, and we have discussed different aspects of the assessment and optimization of these patients in the preoperative period. We also need to look for now, once the things are optimized, these patients will be posted for surgical procedures. So there will be little concerns. We'll be keeping it very brief because that was not the crux for today's session. We'll keep it brief, but I will request Pratishtha to take us forward in brief at how she manages, or what are the standard care plan for the intraoperative management, how you go for the fasting process, and what is your airway management, because these patients may require one lung ventilation at times because of the surgical requirement. How you all go about it? Over to you.
So commonly, as per the ERAS, we should try to limit we should try to restrict it is usually recommended against the prolonged fasting and prolonged energy deficit periods. Usually they recommend the carbohydrate drinks should be given at least 2 hours prior to the surgery. But there's a gray zone again in the esophageal cancer patient, as because these patients may be suffering from GERD or dysphagia, so there's increased risk of aspiration in these patients. So in those specific cases, we can increase we can ensure the prolonged fasting. Apart from this, preoperative advices like long-acting anxiolytics are usually avoided in overall in all the ERAS guidelines. Apart from this, we'll go briefly to the anesthetic plan. In this patient, general anesthesia with thoracic epidural anesthesia and lung isolation techniques will be our plan. And the drug should depend on the cardiopulmonary status, depending on what are the chemo, radiation therapy, and what are the medical morbidities in these patients. Hemodynamic nutrition status, if there's a mediastinal mass effect or not, and the risk of aspiration are also important. As discussed previously, these are at high risk of aspiration, so RSI, modified RSI can be is usually indicated. From the airway point of view, the common used modalities for lung ventilation is DLT, endobronchial blockers, and sorry for the slide, missing components of the slide. But the commonly used devices are the Robert Shaw type of double lumen tubes, and these are very important as these are preferred over bronchial blockers because of the wider diameters, lower airway pressures, easy aspirations, easy removal of the secretions, and we can independently apply the CPAP in these patients, and these are easy to place. But the common drawback is to choose the ideal size of the DLTs in these patients, and that is mainly, and secondly is the more trauma, as these are the longer preformed tubes. And another major drawback is that if the patient has a difficult airway, then we have an additional problem of placing the double lumen tubes. The other alternative is actually bronchial blockers, and bronchial blockers are usually can be easily passed through the single lumen normal endotracheal tubes, and so these are beneficial if we can easily pass the single lumen tube in a difficult airway cases scenario. We can easily pass the bronchial blockers, but one of the drawback is that it requires a fiber optic. These can be easily displaced from the position, and they have a smaller inner lumens for the lung to deflate and for the aspiration of the secretions. It's very difficult in these patients. Apart from this, we have endobronchial tubes and univent tubes also. So from the mechanical ventilation and the post-operative complication, we should always prefer lung protective ventilation strategies. According to the ERAS, 6 to 8 ml per kg of tidal volume during the 2-lung ventilation with a PEEP of 2 to 5 centimeter. And during the 1-lung ventilation, tidal volume to be reduced to 4 to 5 ml per kg of the predicted body weight with a PEEP of 5 centimeter and CPAP of 5 centimeter in non-ventilated lung can be applied. And we should avoid hyperoxia and also allow mild hypercapnia to facilitate the HPV, and that is hypoxia-pulmonary. HPV should be done. So one of the common scenarios that you face during 1-lung ventilation is that the patient can become hypoxic. So what should we do step by step? If the patient has a sudden precipitous fall in the SpO2, we should start 2-lung ventilation to avoid hypoxemic injury in these patients. But due to the effect of 1-lung ventilation, if the patient is gradually decreasing the saturation is seen, we should increase the FiO2 in these patients. We should ensure that the patient tube and the airway devices are properly in place. Thirdly, we should ensure that the MAC is adequate, that is less than 1 in these patients, and also the mean arterial pressure is adequate. Apart from this, we can do lung recruitment maneuver in the ventilated lungs. We can increase the PEEP in the ventilated lung. We can apply CPAP to the non-ventilated lung. We can start low tidal volume ventilation in these patients in the non-ventilated lung also. Apart from this, we can ask the surgeon to stop the to decrease the pulmonary vascular flow in the non-ventilated lung also. Sorry for the missing slides. So now we'll jump to the nasogastric tube. This nasogastric tube decompression is very important to ensure the anastomosis in these patients. But as per ERAS, we should try to remove these NG tubes by the post-operative day 2. And for anesthesia maintenance, volatile or intravenous can be used. Volatile is usually preferred due to the anti-inflammatory measures, but we should remember that volatile anesthetics can inhibit the HPV, and we should always target the MAC value of less than 1 in these patients. As these can be highly morbid patients, so intermediate acting neuromuscular blockers, best monitoring, lung protective ventilation strategies, and we should always aim to do early extubation and reduce the post-operative complication.
Right. So you rightly mentioned about the management, and the fluid therapy is always a big issue. There have been a lot of studies, and many things comes controversial about the fluid management, which, how, when, and how fast. There are many concerns about this, but if you just was to summarize it, probably a goal-directed fluid therapy remains the norm. There were some considerations about the fluid-restricted therapies or goal-directed fluid therapies, because when we are talking about the thoracic anesthesia, intraoperatively probably there will be some fluid restrictions because the lungs become soggy, they are injured, and in those situations the chances of edema is a little higher. And probably in those patients, but then we have to look for the tissue perfusion. That's one of the important aspect, number one. Number two, they should not have the positive balance, because they are already having hindered the bowel mucosa. They have already the issues with their lung, and that's why we should not be overloading them. And this is a huge topic, but the crux will be try to optimize the blood flow and oxygen delivery. Pratishtha, we understand this is a major surgical procedures, probably depending upon you already explained in the beginning that we require sometime a thoracic approach, sometime a thoracic combined with the abdominal approach. And definitely it will be a lot of tissue destruction. and there will be a lot of pain. So how you go about the management of analgesia? Can you just summarize in brief that what are your modalities and what literature says about the perioperative management?
Sir, sorry for the slides again. So the analgesia will be always be focus is always on multimodal analgesia. So from the regional anesthesia and the IV. For the IV, I will go for IV paracetamol, 1 gram should be given. Along with that, thoracic epidural analgesia is considered to be the gold standard, and as per also supported by the IRAS guidelines. Apart from that, alternative is a paravertebral block can also be given. And other drugs like diclofenac or NSAIDs can be given depending on the patient profile due to the nephrotoxicity. And apart from this, magnesium lignocaine, magnesium sulfate can be given in these patients, but it should be the evidence is not very supportive or for or against, and it's also a gray zone. So we should select it according to the patient profile and also the hemodynamics and intraoperative procedures. So in the epidural, thoracic epidural, I will prefer for a local anesthetics with or without any opioids like fentanyl can be given intraoperatively, and I like to continue in the postoperative period.
Perfectly. I think you rightly mentioned that for these surgical procedures, we usually use multimodal analgesia, which is a combination of drugs through various routes, and that's the required. That's one of the standard of care for these patients. And considering the recent concerns about the use of high dose of opiates, probably this multimodal analgesia will be, I'll not say the opiate free, but it will be at least opiate of various local anesthetic infusions are also coming in future, which could be through the blocks or even intravenous use of the local anesthetic agents like lignocaine has also been found useful in improving the pain scores. Simultaneously, they have an opiate sparing effect when we talk about. We also understand that these patients usually are extubated in the postoperative period. Sometimes we use a staged approach. If you have used the double lumen tube, you can skip it using an supraglottic air devices. Majority of time, these patients would be extubated on table because we have already assessed and optimized earlier. But you have to be cautious that in case if they require post-op ventilation, we should be cautious, and we have already discussed these aspects when you're looking for. And when these patients comes in the post-operative care, nowadays we are moving more towards the RAS protocol, and that's why we say the early ambulation, the good amount of chest physiotherapy, good amount of mobility of these patients would be added upon if we start early ambulations. And also, it is well accepted norms, especially in RAS protocols, that all the drains and IVs should be removed as early as possible and use the oral route for initiating the nutrition. We were talking it earlier. It has to be initiated. At times, these patients would be on dysnostomy as a part of the surgical procedures. That needs to be activated at the earliest as soon as these patients are having bowel functions appropriately. And these patients obviously require follow-up for these patients. That is very, very important. Antithrombotic prophylaxis, major surgical procedures, cancer surgical procedures, preoperative radiation therapy to these patients makes them exposed for thromboembolic events. And almost 1/3 of these patients would be at high risk of the thrombotic events happening in these patients, and it becomes very essential to take all measures. We usually use mechanical prophylactic devices intraoperatively using the pumps so that they are okay. We also try to ambulate faster in the postoperative period. In addition to it, it would be a good idea to start them on pharmacological prophylaxis that includes low molecular weight heparin. And in our clinical practice, and even the literature says that once you say the hemostasis is well, they are fine. Post-operatively, maybe post-surgical day 1 in 12-24 hours, we can start them on. So I think these are the important concerns, Pratishtha. But having said that, still these patients at high risk of complication, isn't it?
Yes, sir.
So can you just briefly summarize that what type of complication that you see, what the literature says, so that once we know them, we can assess them and try to optimize them.
So as discussed, as I specified previously, that the pulmonary complications are the most common, and we have read and discussed all the various rehabilitation measures to reduce the pulmonary complications. And other aspect we discussed was the cardiac complication. As we discussed, arrhythmias are the most common, followed by MI and embolism also. And these carry a good amount of morbidity in these patients. So sorry with the slides again. The post-operative atrial fibrillation, prevention of the post-operative atrial fibrillation guidelines have been prescribed by AIIMS in 2018. And they have specified that if the patient suffers from, if the patient was not having any arrhythmias pre-operatively and has developed a new onset arrhythmias in the post-operative period, in the pre-operative or intraoperative period, we should first specify and see as that if the patient is hemodynamically unstable or not. If the patient is hemodynamically unstable and the duration is less than 48 hours, as we all know, we should straight away go to the immediate DC cardioversion. And once we have done the cardioversion, then second is like we should while we are preparing for if the rhythm is still not reverted, or the patient is not hemodynamically stable, reverted back to stable condition, we should prepare for the second repeat cardioversion. And intermediately we can also look for the triggering causes, like any surgical cause, like any irritation or pericardial, if the surgeon is working near the pericardium, or is there any irritation or any drain is there that is irritating the pericardium, or is there any electrolyte imbalance, we should also go and check and stop these triggering factors. Apart from that, the anti-arrhythmic, the rate control drugs like amiodarone, esmolol, metoprolol, dilzim, and digoxin can also be used in these patients. Or rhythm control like amiodarone can be used in this patient, and we can continue the DC cardioversion. Then if the patient is, we look at the right side, we see if the patient is hemodynamically stable, and if it's less than 48 hours, as the patient is stable, we will not go for cardioversion, rather we will go for the initially heart rate control, that is a target of less than 110. We prefer heart rate control over the rhythm control, because it is seen that these patients usually revert back spontaneously to the normal rhythm within 24 hours. So initially we'll go for the heart rate control using beta blockers like metoprolol, esmolol, and dilzim can also be used, or amiodarone can be used. If the rhythm returns to the normal, we'll continue on oral heart rate control measures for 4 to 6 weeks. But if it persists, and if there is a risk that it will persist more than 2 days, we go for anticoagulation. We'll get a cardiology consult, and we can, if the hemodynamically unstable, we go for cardioversion also. But if the only difference is when the patient is the atrial fibrillation duration is more than 48 hours, we have to start anticoagulation, as there is a risk of thrombus. And apart from anticoagulation, we'll also start the heart rate control measures. Along with that, we can perform cardiac consultation and exclude the LA thrombus or not. And if these patients, if the rhythm is still not controlled, we'll go for oral heart rate control medicines can be continued along with the anticoagulation for the 4 to 6 weeks. And cardioversion can be done if the patient undergoes, if the rhythm and rate are not controlled, once we have excluded the thrombus also.
Right. I think this is one of the issues which we see, and majority of time it will be a benign type of arrhythmias which may not require. And the prophylactic treatment of these atrial fibrillation is not desirable as per the various guidelines, and we should try to look for about the stability versus instability in these patients. And we can use the drugs as required in case if they have AF, so that this settles down. And some other complications which probably is little perioperative may require our interventions, maybe the anastomotic leak, because sometimes these patients who have chemo radiation, their tissue becomes friable. Sometimes they could be infective focus because they are immunocompromised patients, and hence there could be the possibility of anastomotic leak. And usually it starts happening 3 to 4 days later. And we need to identify them earlier, because if the anastomosis has been done in the mediastinum, the mediastinitis, if it happens, it has a lot of morbidity as well as mortality. And that's why it's early identification, especially those who are taking post-operative care or even the critical care, needs to identify them at the earliest and try to take care of these patients. We did mention about the pulmonary complications. At times, these patients are elderly patients. They may have post-operative delirium. We need to identify them, because even the delirium has been identified as one of the reasons for increased morbidity and mortality. Thank you, Pratishtha. You have nicely covered most of the aspects of esophagus surgical procedure, though it's challenging. I'm sure that the way you have presented will make us understand many important aspects. I'm sure the listeners today would have also got benefited from the various aspects and we have more focused on the pre-operative aspects, optimization aspect, rehabilitation as well as rehabilitation. Many more things for the intraoperative period. Probably we'll put it in some time later in a detailed session. We were, instructed to talk more about the pre-operative period, so we did it, and we are open. I'm happy that many of the senior persons with a lot of experience would be there with us. So I would request if somebody has any comment or any suggestions, most welcome, and we will take it forward.
Right. Is there any questions available?
Sir, there is one question which has come from Dr. Taj Gopalan. He is asking how many days we should take up for surgery after chemotherapy. I think Dr. Pratishtha has mentioned. Can you just repeat it one? We do have guidelines. So let's little expand it. If you can repeat it, Pratishtha. The chemotherapy, and as we discussed in the session, these patients sometimes probably would receive combination of chemotherapy and radiotherapy. So how much duration should be optimal for the surgical intervention?
So as per IRAS guidelines, they have specified if the patient has received only chemotherapy, a period of 3 to 4 weeks is good. And for the chemoradiation therapy, 6 to 8 weeks has been specified as an optimal time period before the surgery patient is taken up for the surgery.
Is there any standard protocol, or we accept a patient whenever the patient is ready? When in your terms, the patient is fit to undergo the surgery as soon as the post-operative days.
So regarding the, you're talking about the optimization status?
Yeah, that's the optimal status. But you have done the chemoradiation and probably you are waiting for the surgery. Is there any particular specific period of time after radiation or chemo? Or you say, whenever you feel the patient is good, patient is fit, patient can tolerate the surgery, you take up the patient, whichever.
Sir, you have asked a very, very important question, because we have to balance on two aspects. One is the side effect of the chemoradiation should subside down to a acceptable level. There will be long-term side effects, so we cannot wait for long-term. On the other hand, we have to do the surgery at a time when we can get the maximum benefit of the tumor suppression or tumor shrinkage because of chemoradiation. And it has been found, and if I put it very blanket for just not for esophagus, but for many other surgical procedures which receive chemoradiation preoperatively, we usually say that 4 to 6 weeks is the optimal time for these patients to be posted for surgical procedure.
That's what I
Having
was
said that,
yeah.
Having said that, we also need to look for that the tolerability or the response of the various chemotherapeutic and radiation is very variable among the patients. And if they have not tolerated well, and if they are spontaneous regression of the side effects, especially when we talk about it is the cardiac system and the respiratory system, has not become to a near normal level or to a near pre-radiation or chemo exposure, probably we'll need to wait for some more time. But that is an individual assessment of these patients for toxicity vis-a-vis the right timing. And that's why these patients will be on the regular follow-up. But majority of time, we are okay at 5 to 6 weeks for these patients to be posted for surgical procedures. And also, if we try to optimize them or prehabilitate them, obviously the recovery becomes appropriate during this interval, sir, and we are able to take majority of patients during this window period of neoadjuvant chemoradiotherapy, sir.
Right. How do you plan out your post-surgical rehabilitation of the patient? Post-surgical rehabilitation in the sense, well,
right.
So
post-surgical,
yeah.
So post-surgical rehabilitation, if we talk about, sir, post-surgical rehabilitation we talk about are a couple of things. One is these patients, after undergoing a major surgical procedures, they need to be nutritionally replenished because they're already nutrition depleted before the surgical procedures. So when we talk about rehabilitation, let me put me into multiple aspects. One is the major organ system that we need to look for. Second is the nutritional aspect. Third is the mobilization aspect. And fourth is these patients should have normal bowel actions also. So we need to target all those things. And when we talk about, we prefer to have early nutrition. We need to have early enteral nutrition. Sometimes these patients may receive jejunostomy. We can start them on enteral nutrition at the earliest. This is one. Second is early ambulation is very, very essential. We try to mobilize them on day 1 or day 2 if everything is fine, and that becomes a very, very important. Third aspect is the respiratory rehabilitation, because these patients has undergone the insult to the lungs, and because they'll be handling a little bit there, there'll be one lung ventilation, there will be some physiological damage, some insult to the lungs, and that rehabilitation we usually start preoperatively, continue intraoperatively and postoperatively. For example, say incentive spirometry, the lung rehabilitation, the secretions loosening, and it's taking out the full bronchodilator therapy to these patients. So these also needs to be continued in the postoperative period. And we say it's a rehabilitation because patient was having underlying baseline issues with this. Similarly, for the cardiac cause, probably the perioperative period, once patient undergoes these type of surgical procedures, they will have sometimes the arrhythmias, and that also needs to be looked for. Majority of time they are benign, but definitely sometimes they will require a rate control and they will be on drugs, and we need to wean them off once we have ruled out there is no much insult to the cardiac functions. So these rehabilitation becomes important and needs to be followed up. And since these are cancer survivors, there is one of the important issues is the persistent post-surgical pain. And we have seen that almost, especially who has undergone the procedures through thoracotomy and laparotomy, is almost 1/3 of these patients will have persistent post-surgical pain, which mandates that these patients must receive good perioperative pain management, because this is one of the important parameter. We give some good perioperative analgesia. In spite of it, we need to continue them. Sometimes they will have pain at the incisional site on both the scars, thorax and abdomen. They may require some interventions like radiofrequency ablation for the thoracic intercostal nerves, and subsequently maybe some other interventions also. So that again becomes a part of rehabilitation, because pain is very debilitating and we are able to manage it to a large extent.
Good. Thank you very much. Any other questions?
So there are 2 questions on the chat, sir.
Chat box, yeah.
Dr. Priyanka Goyal wants to ask, how do you manage subcutaneous emphysema? Do you extubate such patients, Pratishtha?
So we hardly see any patients with cutaneous emphysema. As we know, post-operatively, these patients already have an ICD, especially on the right side. But if the subcutaneous emphysema is usually what is the cause of subcutaneous emphysema, secondly, giving a high oxygen therapy to these patients, we can easily manage subcutaneous emphysema if it's benign. But if it's very gross, that is very rarely seen. I've personally not seen any. But if it's compromising the air, like it is neck region and area, and it is there's a risk of compression of the airways, then we can think about, and we should always exclude what is the cause of subcutaneous emphysema, as already ICD is inside. So air should not be leaking into the subcutaneous.
Right. Even if it happens, I think it's very rare. Depends upon the surgical technique. But if it is, it will be very mild, and it will be just conservative management. You don't have to intervene very strongly for it. But yes, obviously, it is more of a surgical technique based. We hardly see actually any subcutaneous emphysema happening in these patients. Dr. Vasidot Dayam, sorry, I think I am speaking right, wants to ask NG tube removal according to the RAS, it is within 24 hours, but in esophagectomy, it will be considered, for esophagectomy, because I mentioned that one of the big concern is about the dehiscence at the surgical site, and it is not directly amenable, and mediastinus is having a huge complication. That's why we mentioned into a slide that they are kept on jejunostomy for some time, and that feed it through it. Once they are sure that the anastomotic site which sits into the mediastinum is well healed up and it will not leak, and that's why there would be some delay. I fully agree. RAS protocol says remove all catheters and lights within 24 hours, but these patients probably would require, but still we believe that majority of these patients would be off NG tube maybe on 2nd and 3rd day majority of time.
Yes, sir. Even ERAS has specified in esophagectomy guidelines that they should be removed. They can be kept at least POD2 for the decompression.
Yes. Dr. Priyanka Goyal wants to ask if there is contraindication for epidural. How do you manage pain after esophagectomy and extubate? I think, Dr. Priyanka, we are absolutely happy with our multimodal analgesias. We are using combination of techniques. Being a teaching hospital, we do a lot of research as a part of dissertations, and that's why we experiment with various techniques. Most conventional, if you say, standard of care remains in earlier days to be thoracic epidural. But if you see, like my personal experience, I use a lot of intrathecal morphine, which is again, though my personal preference, but it is there in the literature for last almost 2 decades. I'm not only reducing the dose of opiate requirement, because single dose of 5 to 7 micrograms per kg of morphine works very well for 24 hours, and then subsequently we can ship them on epidural route. You can use either the opiates, or you can use the combination of local anesthetic with opiates, or even the local anesthesia, which is again an important thing when we talk about the opiate sparing or opiate free anesthesia. All these techniques are very well done. People have tried to use even in the recent the facial plane blocks. They're also working well. They have inserted the catheters. They are working well. Paravertebral block has already been used earlier. But I think sticking to the thoracic epidural or epidural is one of the acceptable norms. But remember, they have to get approach from two aspects, one thorax and one abdomen. Dr. Priyanka again wants to ask the transfusor trigger in robotic esophagectomy. I think when we talk of the oncology patients, we have patience in ourselves not to transfuse each and every RBC loss during the surgical procedures. We are happy with 8 gram per deciliter for majority of our patients. Once you have optimized them nicely, if their cardiorespiratory functions are very well done, we are absolutely happy with 8 grams. And you can take further decisions based on the oozing or the loss of blood from the surgical site. But 8 is acceptable norms. We do not over transfuse them with excessive PRBCs. One, we don't want more transfusion. Second, it's a cancer patient. Third, it leads to immunomodulations, increased chances of infections, which we do not want into our oncosurgical procedures. That's why we are cautious about it. So I think, sir, we have Madam Sood, Madam, and Dr. Radhakrishnan. We have covered most questions, ma'am. I'm
Yeah.
sure, ma'am.
Rakesh, did we talk about the level of epidural? She had asked that also.
Yeah,
Thoracic
ma'am,
epidural.
we mentioned we usually go
See.
for an incision congruent where the
Yeah.
thoracotomy is done. So
Right.
usually we give incision somewhere in T5 or T6 level. So we go from T8 and the tip is around T5 and T6. We are able to
Right.
take care of it. But we need also to remember sometimes, I mean, many of the times they will go for the abdominal approach also. So that part also should be covered up. In those situations, we go a little lower so that we can cover from same catheter both the aspects, the thoracotomy approach and the laparotomy approach.
And midline approach or paramedian, which one do you take?
Ma'am, we usually go for midline for majority of
Midline.
our patients. Yes, ma'am.
Good. Thank you. We had a very lengthy, exhaustive, good dissection. I request Dr. Jayashree to take over.
Thank you, Dr. Radhakrishnan. Thank you, Rakesh, and thank you, Pratishtha, for this excellent webinar that we've had on a very, very important topic of oncoanesthesia, in which, as a case discussion, we talked and discussed about pre-op, optimization, CPET, and all the important things, of course, perioperative and post-operative. I think in this webinar, we've actually covered every part of oncoanesthesia, which is, of course, a very important specialty. And you can see how Dr. Rakesh and Pratishtha, they have so much experience in this oncoanesthesia that all the tips that they have given will go a long way for all the students and the consultants who practice some kind of oncoanesthesia. So thanks a lot, Pratishtha. That was very nice. And thanks a lot, Rakesh. We covered actually every part of it. And truly very, very impressive. Thank you very much. And we'll see you sometime next week or sometime soon. Thank you, Dr. Radhakrishnan.
Thank you. Thank you. Good night to all. We'll be seeing soon. We'll be seeing soon.
Thank you very much. And good night, everybody. See you all next week. Bye-bye.
Good night. Good night, everyone.
Bye.
Thank you so much for entrusting us the opportunity to host the session today. I hope you all had a seamless and hassle-free experience. So with all you do comment, we would like to conclude the session over here. I'm really looking forward to hosting you. Thank you, everyone. You all can leave.